Hi, greetings from London, and I welcome you all to this combined SECEC and EUSSER webinar on shoulder instability. My name is Jagwant Singh, and I'm the chair of the Healthcare Delivery Committee. We have a extremely experienced and renowned faculty who will be taking us through this program on the shoulder instability, and I'm grateful to them. We have Bart-Jan, who is an orthopedic surgeon in Netherlands, and he has great experience in management of shoulder instability and with his fellowships, and he'll be talking to us about labral repair and remplissage. We'll be joined by Clara Azevedo from Lisbon, Portugal, and she'll be talking to us about dynamic anterior stabilization. And we will also, and she'll be joined by Ana-Catarina, who will also be speaking on the same topic. And both of them are prolific speakers. They are lecturing nationally as well as internationally. And Ana-Catarina is one of the founding members of the Global Elbow Network. She's on multiple committees, including the Shoulder and Elbow Society. We'll be joined by Berte Bøe from Oslo. She's the former president of the Norwegian Shoulder and Elbow Society and the vice president of the ESCA. Margie Olds will be joining us from Auckland, and she'll be talking about her experiences with elite athletes, along with Dr. Edel Fanning from Dublin, who will share her experience about elite athletes and dislocations. Carlos Cobiella is a colleague of mine here in London. He is the chief of the upper limb unit in the shoulder in the exercise and sports unit at the UCL. He'll be talking to us about the bone block. He's an innovator and he has been on faculty on multiple courses. Professor Olivier Verborgt, thank you for joining us, and he's the president of the Belgian Shoulder and Elbow Society, and he'll be talking to us about latter-J. Charles Getz will be joining us from Philadelphia, and Charles will be talking to us about posterior instability. Solenn Gain is a colleague of mine on the Healthcare Delivery Committee, and she will be talking to us about instability management. And we also have Matteo Mantovani, who talks about innovation and about pacemaker in posterior instability. So it's a full-packed session. And thank you to all the speakers and all moderators who have given up their time and they're moderating the session. We have Mohy Taha from Zurich, and he's on the shoulder and elbow surgeons. He's founder of My Fellowship, and he's also an international best-selling author. Marius Negru is a founder of and president of the Romanian Shoulder and Elbow Society. He's widely trained in UK, and he currently practices in Spain. Anju Jaggi does not need an introduction. She has spent about 25 years in management of instability. She's been a former EUSSER president, and we're also joined by Mr. Joydeep Sinha, who is a senior shoulder and elbow surgeon at King's College London, and he is moderating the session. Many thanks to all the moderators.
I'm Marius Negru. I'm one of the moderators for tonight's first part of the evening. I want to welcome everyone to this evening's SECEC Instability Shoulder webinar. It's a pleasure to see so many colleagues and participants joining us from across Europe and beyond that, for what promises to be a very engaging and insightful session. As your moderator, I will be guiding the session, so please address all the questions in the Q&A sessions. Together with Dr. Taha, I'm going to be trying to put all the relevant questions to the speakers. Thank you very much.
Also, welcome from my side. It's my pleasure to welcome you all to this joint venture with the physiotherapist and orthopedic trained surgeons for instability. We are very happy to get you all again together. And last but not least, looking forward to seeing you in the SECEC meeting in Rotterdam.
Okay, thank you very much. I'll start with the first talk about Bankart repair and remplissage. Again, thank you for the great opportunity to talk about this topic. I live in the eastern part of the Netherlands. What are we going to talk about? First of all, the definition. We're going to talk about traumatic unilateral glenohumeral dislocation, which is different from multilaxity. And the treatment options are obviously non-operative treatment. Every physiotherapist is familiar with it. We have the Bankart repair, the Bankart with remplissage, which I'm going to talk about, the dust, the free bone blocks, and the ladage. But with each procedure, the stability increases from 20% noted for Bankart repair up to less than 5% redislocation rate for ladages in literature. But with that, the complication rate increases. With Bankart repair considered quite safe concerning complications, but ladages have a noted complication rate of up to 15%. So that's quite a difference. So what to choose from these options? Obviously, you want to take into account the number of dislocations. We hope that the reduced trial, which is recently started, will give us some answers about first-time dislocators. Patience factors. The ISA score is quite helpful, developed by Pascal Boileau. We evaluated it recently, and if you score more than 3 points, you definitely want to consider different treatment. Collision sports, well, these kinds of sports might benefit from bone block and quite firm surgery, so you want to refrain from soft tissue procedures. In my practice, I want to look for the bone loss. So everybody gets Berne-Go views of both shoulders, and then I look for bone deformity. And if I have any doubt considering the glenoid, I perform 3D CT scans to take a closer look at the glenoid and help that fact into my decision. We are all familiar with the on-off track concept developed by Professor Itoy. And it helps you to guide which treatment option. On the other hand, I will explain later on as well that also on the on-track Hill-Sachs lesions, remplissage can help quite good. And you want to take a look at the soft tissue quality, of course, because some patients, the labrum is totally deteriorated, not visible anymore, so you won't get any grip with your anchors. So how to make your decision? Well, this recent published classification helps me a bit about thinking about the different factors. So you want to take a look at the glenoid bone loss. You want to judge the labrum, the quality of the capsule. You take a look at the Hill-Sachs lesions, and these you can all do on MRI, on CT scans. And then you base your treatment, including all the other factors, but these help for MRI. And then you can choose your different treatment options. So every shoulder surgeon and also the shoulder physiotherapist are familiar with the standard Bankart procedure, right? You freshen it up, the bone defect, the bone edge, and you put some anchors and sutures in, and you, with most of the time at least 3 anchors. But is it enough to give your patients a stable shoulder, which is also durable? Because in literature, up to 20% have a redislocation rate, which I think is not acceptable for my patients. So maybe we should add a remplissage. What does it mean in French? The remplissage, filling the hole. So what you perform is a capsulodesis and also a tenodesis of the infraspinatus muscle into the defect of the Hill-Sachs lesion. How do I do it? What is needed? Well, you can use an insertion kit that helps me to put in the anchors, but you also can use suture hooks from the subacromial space. And I like to use interconnected tensionable suture locking anchors because that helps me to do a knotless suture bridge. But you can also use corkscrews or any other type of anchors. Every company has anchors available, right? This is how I do it. So I use a needle-guided needle-guided portal placement in the B position, where I keep my camera all the time intra-articular. After I did the Bankart, I do put in a twisting cannula with the tip subacromial. So I pinch a bit into this infraspinatus, but I don't put it through. And with that, the camera stays posterior. And I don't think it's beneficial to use a burr because synovial lining won't adhere to bone. so I don't do that. And then I put 2 anchors in a vertical position. And then I perform my Bankart repair at the front side of the shoulder. After the Bankart repair, I go back looking at the back side into the heel sex lesion, and then I start connecting the sutures for a suture bridge. After connecting, I put one suture in one anchor and the other one vice versa, and then I start tensioning, and at the end, no knot is needed. So this is how it looks like during surgery. I put one suture into the other anchor, I start pulling, and then as you can see, the infraspinatus is filled into the heel sex defect. And with that, after that, I do it also with the other anchor. And with that, we have a tight suture bridge. So what is the evidence for this procedure? Well, I think it is safe, it is effective. You don't have any loss of external rotation, which was we worried about in the past. The on-off track lesion doesn't really matter. So I think you should have a very low threshold when you consider the Bankart repair, obviously when there is also a heel sex lesion. So where did I get this reference? Like every student, I go to FUMEDI and I have a very convenient, a lot of talks are available. Professor Rondelli already told me, well, you better use a remplissage. It is my preferred stabilization as well in the clinical, in the case of glenoid bone loss less than 15%. Michael O'Brien from the US says, well, I like to use the remplissage all the time. George Atwal also has a nice talk on it, and he says, well, I do it every time when there's a heel sex, and it doesn't matter if there's an on or off track lesion. Like in every topic within shoulder surgery, our colleague Hurley already made a review about it. So he took a look at remplissage for anterior shoulder instability, and they combined the data of 12 studies, including 740 patients, and they saw that the total recurrence rate for arthroscopic Bankart repair with remplissage is way less than doing only a Bankart repair, which also is true for the recurrence rate when comparing arthroscopic Bankart repair with remplissage compared to the Lattier. They have comparable recurrence rates. So also, but when looking at the complication rate, comparing arthroscopic Bankart repair with remplissage versus Lattier, well, there's quite a difference that the Lattier patients have way more chance of having a complication. So in conclusion, they say that subchirurgical bone loss with a heel sex lesion, you should perform an arthroscopic Bankart repair with remplissage as it has the similar recurrence rate, good prompts with lower morbidity and fewer complications compared to a Lattier. But then we also worry about external rotation. Well, a recent published study by Patrick Dinard, they combined the data of 27 studies, including over 20,000 patients, and they saw that there was no difference in the mean loss of external rotation. There were some difference. So the arthroscopic Bankart repair, 7 degrees of difference was seen, loss of external rotation. With the remplissage, it increases up to 3 degrees, and for Lattier, not that much external rotation, but it was not a significant difference. So they conclude that remplissage may reduce the risk of reoperation compared with Lattier, but with no difference in postoperative external rotation deficit or recurrence. So not much difference, eh? So to conclude again, remplissage. I think it is safe, it is effective, there's no loss of external rotation, the on-off track lesion doesn't matter. So I suggest you have a very low threshold when you consider a Bankart repair. Thank you.
Thanks a lot, Bart, for this very interesting presentation about remplissage and the technical guides you gave us. We'll keep all of the questions at the end of the session. So I would like to introduce one of my good colleagues, Clara Azevedo from Portugal. She is a consultant for orthopedic and trauma. She has completed her medical degree in Lisbon, and she's a former assistant professor of Nova. She co-founded Shoulder PT or Portugal, and she will be joining us with a video presentation.
Hi, it's an honor to participate in this SECEC-EUSSER webinar chaired by Jag. Thank you so much for the kind invitation. I'm going to make a short introduction for the dynamic anterior stabilization, and then Ana-Catarina Angelo is going to follow up with the surgical technique. I have no conflict of interest. Why did the dynamic anterior stabilization come up? We have a solution for glenohumeral instability with minor to no bone loss, which is the Bankart procedure. And for patients who have more than 25% of anterior glenoid bone loss, the Latarjet procedure has very good outcomes. However, in the subcritical anterior glenoid bone loss, between 10 to 20%, there's still a lot of controversy regarding the optimal procedure, because if you use the Bankart procedure, you risk losing external rotation significantly because you're pushing your repair posterior inferiorly. If you use the Latarjet for subcritical glenoid bone loss, even though you have much lower recurrence rate than with the Bankart repair, you risk having other sort of complications, mostly related with heart, which can range up to 30% in some series. So this is why some surgeons start to look for an alternative to avoid these risks of lesions caused by the bone on the humeral head cartilage contact, the risk of the hardware contacting the cartilage and destroying it in very young patients, and also the risk of damaging the musculocutaneous nerve by placing traction on the conjoint tendon when you transfer the coracoid with the conjoint tendon to the anterior glenoid, and also risking with your retractors in an open Latarjet to damage the axillary nerve. So it seemed that this technique could be an overkill for subcritical glenoid bone loss, and this is why the dynamic anterior stabilization was proposed, to have a solution where you use no bone, so avoiding all these risks. No hardware, you don't transfer the conjoint tendon, you're transferring the long head of biceps through the subscapulary split, so you don't risk damaging the musculocutaneous nerve, your lateral to the axillary nerve, and this was mainly the most interesting aspect of using this technique. What is this technique? You're transferring the long head of the biceps to the anterior glenoid. And it seems that the first proponents that published this technique arthroscopically were Philippe Collin and Alexander Laderman, and they used an interference screw to fix the long head of the biceps through the split of the subscapularis tendon medial to the articular surface of the glenoid at the 3 o'clock position, and they used this to augment the Bankart repair. It was also published an alternative way of fixing the long head of the biceps. Instead of inlay, like by Philippe Collin and Alexander Laderman, onlay, so on the articular surface, instead of medial, lateral. And this way, Oleg Milina and Bruno Tasson proposed in 2019 to repair the long head of the biceps to the anterior glenoid, working not only as a sling and a hammock like the Latarjet, but also as a labroplasty, increasing the concavity compression of the glenoid and theoretically being more stabilizing. We described a modified technique of this onlay dynamic anterior stabilization in 2021, and we showed that using our technique, the first 3 patients healed the long head of the biceps to the anterior glenoid in MRI controls at 1 year of follow-up. Then we published the tips and tricks, and Catarina Angelo is going to explain how we perform this procedure to achieve this onlay labroplasty effect in the anterior glenoid using long head of the biceps. So paramount for a good result in our patients is that they start immediately externally rotating their shoulder. Sometimes I show them this video to show them that they can immediately start fully externally rotating the shoulder so as to avoid adhesions between long head of the biceps and the subscapularis tendon split. So at the first 6 weeks, we just restrict our patients from performing resisted flexion of the elbow. So the main goal here is to protect the healing of the long head of the biceps to the anterior glenoid during this period, but they immediately, as I just said, start fully externally rotating their shoulder to avoid adhesions and to avoid loss of external rotation, which is one of the major advantages of this procedure. And then after 6 weeks, they are allowed to progressively strengthen their biceps, but they also start since day 0 to forward flex their shoulder completely with assistance. This is how we manage to have full range of motion, at least at 6 months of follow-up in our patients. We've done this procedure in 49 patients. One of the advantages of this procedure is also addressing the slap lesions. We actually had more than half of our patients with slap lesions as well. On average, our patients had a subcortical glenoid bone loss of 8%, ranging from 0 to 20%. Most of the patients were on-track bipolar lesions. We already have 24 patients with more than 2 years of follow-up. We did have 2 recurrences in our series, and these were patients who were severely hyperlax. Since our 26th patient, we started adding the Hill-Sachs remplissage to all the patients that have bipolar lesions, regardless of being on track or off track, to increase the resistance to anterior dislocation. We had no biceps complaints. And so in summary, this is a dynamic technique where you have the hammock effect of the long head of the biceps pushing the subscapularis tendon down in the first degrees of abduction and external rotation. And then you have the sling effect in front of the humeral head, avoiding the anterior dislocation. When you do the technique, as Catarina is going to describe, the onlay technique, you have a laboroplasty effect that has the potential to increase the concavity compression and be more stabilizing for the glenohumeral joint. You don't lose external rotation, and several biomechanical studies have shown this, and it's paramount that you instruct your patients to immediately start externally rotating the shoulder after this procedure. It decreases the anterior glenohumeral translation in patients with anterior glenoid bone loss ranging from 10 to 20%, deals with the slap lesion, so you feel 2 needs with 1 deed in this procedure. In our technique, it's all suture anchors, no hardware or neurovascular complications are reported because we're far away from the axillary nerve and we don't place traction on the musculocutaneous nerve. Only small pilot holes are needed for the all suture anchors, so it makes for easier revisions, and also you have no metal and therefore no CT scan artifacts if you need to control these patients. And you can do this with only 3 portals and adding 1 more for the Hill-Sachs remplissage. You don't need any specific instrumentation, so if intraoperatively your patient has a bipolar lesion that needs more than just a Bankart repair, you can convert to this procedure with the same instruments, which is different if you need to do an arthroscopic lateral. Nonetheless, there's the disadvantage of the delayed return to play. At 6 months, you have to have these patients muscularly robust before you can allow them back to play. This is safe for chronic glenohumeral instability with less than 20% of anterior glenoid bone loss, with or without a slap lesion. If you have a bipolar lesion, either on track or off track, Hill-Sachs lesions, you can add the Hill-Sachs remplissage to increase the force necessary to dislocate this shoulder, and this is interesting for collision athletes. But if you have a patient with severe hyperlaxity from 8 to 9 in the Baton score, you should also repair the inferior capsule to avoid inferior subluxation under your dynamic anterior stabilization, or augment with a Hill-Sachs remplissage if they have a Hill-Sachs lesion. And you're invited to our course in September. Thank you so much, and go Catarina.
Many thanks to Clara for the great presentation and the video documentation. And now it's my pleasure to introduce Ana-Catarina Angelo. She is a co-founder of Shoulder Portugal. She is a team member of the University of Lisbon. She completed her residency and fellowships in Portugal, France, and Belgium. She has published extensively and serves on multiple journal editorial boards and a member of the board. So it's my pleasure to introduce you.
Hey, Mohy. Hello, everyone. Welcome. I will make my presentation a little bit faster to compensate for Clara's. So thank you so much for having me here today. I'm just going to talk a little bit about the technical pearls and pitfalls. Clara already explained what is the DAS. It's basically a transfer. So you cut there and you transfer there. So it's very, very simple. I could end by now my presentation. I'm just going to say some tips and tricks for you to do it uneventfully. So we have 2 types of techniques, onlay or inlay, regarding the place of fixation of the biceps. Our technique is an onlay technique. We use 3 portals. We add the 4th portal if we're going to do the remplissage, which we have been doing, as Clara said, in the last more than 20 patients. So we use the posterior soft portal as a viewing portal. We use a first working portal in the rotator interval and the second working portal in the groove just above the long head of the biceps. And this is a small video of a DAS. So here we already performed and placed the anchor for the remplissage. Before we tie these knots, we proceed with the DAS. The first thing that you do is you really have to clean the rotator interval. So you use your first working portal, and with the ablator, you just clean everything superficial to the subscap. Then if you still have a labrum, you prepare your anterior inferior glenoid and you release the labrum so you can repair it over the DAS at the end. Then you mark the spot of your two anchors. Usually we do it at 4 and 5 o'clock positions, as you can see there, and you use these marks to level our split. So in the DAS, in our technique, the split ends up usually between the upper third and the lower 2/3 of the subscap. As we're coming from lateral to medial, what we see is that it's the split, it's much more lateral, it's tiny, and it doesn't endanger any nervous structures. So on the other side, you saw the conjoint tendon, we don't go medial to it. It's very important, this step, that you place the anchors through the split. And then you're going to pass the sutures from the first anchor on the biceps. So you pass one blue, you park it, and then you pass one white, and you park it on the anterolateral portal. You tie the knot outside, and you're going to shuttle it in by pulling on the opposite limbs. Then you cut this knot, and you're going to pass the remaining two sutures. These sutures are from the 5 o'clock anchor, so they are more lateral, more close to the groove. Then you repeat everything again for the 4 o'clock anchor. But these sutures, you're going to pass them a little bit more medial. So you pass one blue and then one white. You park them both in the anterolateral portal, and then you tie the knot outside, you shuttle it in, and you pass the two remaining sutures. After this, you're going to have to cut the transverse ligament for the biceps to be able to dislocate anteriorly, as you're seeing there. Then you're going to cut the origin of the biceps on the superior labrum so that you can transfer your long head of the biceps to the anterior inferior glenoid. And with this technique, what you're going to do is that you're going to pull on the opposite limbs, and you're going to use this double pulley to shuttle the long head of the biceps to the anterior inferior glenoid. So you start by pulling on the 4 o'clock ones to help the biceps go through the split, and then the 5 o'clock one. And what you're aiming is for this shape, this L shape, that is going to recreate or to do a labroplasty effect. If you still have a labrum, you can pass the remaining sutures through the labrum, and this will bring the knots out of the joint, okay? Here you can see from the anterolateral portal, the biceps running smoothly through the split and your conjoint tendon on your right side. Here you can see the effect achieved. So if we're going to push the head of the humerus anteriorly, the biceps will act as a seatbelt, and this is the effect that we're aiming with this technique. So when the patient does abduction and external rotation, as you're seeing here, the biceps doesn't let the humeral head luxate or dislocate anteriorly. And this is the same patient from the video at 6 months post-op, is very, very confident about his shoulder, and he has no apprehension at all. So as a take-home message, this is one of our first patients. This was very early after his surgery, so you can still see that the biceps is a little bit atrophied in regarding the other side, and this is because we protect the biceps. Okay, for the first 6 weeks, we don't let them flex the elbow against resistance, and the biceps usually loses a little bit of volume, but then they recover uneventfully. So no biceps complication. So DAS is very promising. You can adapt this technique to whatever fits you. You can use whatever instruments you're used to use. You don't need any special set to order. So if you're planning to do a Bankart, but you find that you don't have a good labrum, you can still do a DAS using the same implants. This graft is usually available in every patient. If you use our technique, there's no hardware, as Clara already mentioned. And if you have a slap lesion, this is a perfect solution. So thank you again for your attention, and I hope to clarify all your questions at the end. Thank you.
Thanks a lot, Anna, for taking us through the technique and the video details. I would like to hand over to Marius to continue introducing the following speakers.
Well, great talks. Thank you very much, everybody. So I think we'll move to Berte Bøe from Norway. She's in Oslo now, and she's going to talk to us about the superior labrum tears, whether we repair them or we do a biceps tenodesis. So Berte, hand over to you.
Thank you very much. It's a pleasure for me to be a part of this SECEC-EUSSER webinar about shoulder instability. So thank you very much to the organizer for inviting me. Yes, my topic is biceps and slap. And I'm just seeing so many pictures. Sorry, there we go. Yeah, so we know that in overhead athletes, this is a commonly common injury, and it might be from a single trauma or repetitive micromotion or degeneration. And often the mechanism of injury is either a forceful traction to the arm or a direct compression. And of course, it might also be because of repetitive overhead throwing. So the challenges in this symptoms and diagnosis is that it overlaps sometimes with rotator cuff symptoms. And if you misdiagnose this, it might end up in persistent pain in these young active athletes and also poor results of your surgery. So most of us are familiar with the SLAP classification from Snyder from the old days, from 1 to 4, where it's not much discussion about SLAP 1 with fraying. Most of us would leave that without doing surgery. And also for 3 and 4, where there's a bucket handle or a totally loose insertion of the biceps, then we recommend surgery. So the controversy is about SLAP 2. And we also know that this classification has been extended to 5 to 10 also in the later years. So a little bit about the biomechanics in the throwers or the overhead athletes. We know that for the throwers to achieve the much power they need to throw, and they have so much external extension to have this force. So the insertion of the biceps have to be flexible to some degree. And we also know that if you have a small tear, probably the biceps tension might create further progression. So in the cocking or throwing, the labrum provides both a bumper effect for posterior translation, and in the follow-through, the biceps labral complex helps to control the translation. So my diagnostic workup is a set of clinical tests, because I think that because many of these tests have limited specificity, you need a kind of a package. And I think that the examiner should use a package that they are familiar with. And for me, that would be for suspected SLAP lesion or biceps trouble, the O'Brien test, and also some kind of external rotation and abduction test. For example, the modified dynamic labral shear test. Because in this position, if they have a problem with the insertion of the biceps, they might often have pain in the posterior part of the shoulder when you are provoking this. And also palpation of the sulcus and biceps provoking tests. So the clinical examination is, of course, important, because sometimes we get an MRI response that there's probably a SLAP lesion. And we also know that the sensitivity of normal MRI is not that high, a little bit higher if you have an arthrogram. But false positives are common, and we must also be aware of the variation in anatomy, that for some patients it looks like it might be a tear, but when you do the scope, you realized that this is not really an injury. This might be a anatomic variation. So we need to put all these things together. And I also had to remind you about that for some athletes, they develop some asymptomatic labral tears from the superior glenoid. And this adaptive pathology is necessary for the throwing athletes to achieve the maximum strength in maximum external rotation to facilitate the maximal velocity when they throw. So this used to be the split up between who should have slap repair and who should have biceps tenodesis if you ends up with surgery. Of course, the first choice would be non-surgical treatment. But if you have tried that and failed and you go on to surgery, this has been the discussion. And Owen Hurley has been mentioned here earlier because he had done a lot of systematic reviews. And we find support for this split in his review from 2018 that the young overhead athletes should be operated with a slap repair arthroscopically with suture anchors. But we also knew that they had variable outcomes and a high risk of stiffness after the surgery. And we also thought that the older or non-athletic population did better with the biceps tenodesis, either technique you choose, and that this could give pain relief and faster rehabilitation compared to slap repair. However, after this review, it started to come more reports that maybe the difference is not so big, and maybe also patients below 35 years or below 40 years could have a biceps tenodesis. So Hurley did another review here in 2024, where he looked at those young patients below 40 years, and he found that in 5 studies comparing biceps tenodesis with slap repair of type 2, ended up with the same outcomes. So no difference between the techniques. I cannot talk about slap surgery without mentioning this high scientific level study from Norway, Cecilie Pine-Skrøder. She actually randomized to 3 groups. She included also a sham surgery group comparing to slap repair and biceps tenodesis. This was a wider spectrum of age, but no matter, after 2 years, both her primary outcomes and also other proms and shoulder scores show that there was actually no difference between doing a repair of the slap, doing a biceps tenodesis, or doing a diagnostic arthroscopy with no reparation. So this is something to have in mind, and this is also something that supports that we should really consider conservative treatment for a pretty long time before we take the athletes to surgery. But we are surgeons, so when it comes to surgical techniques, I want to say a few things. And about the slap repair, remember to not make it too tight, because some of the athletes, they need some mobility in the insertion to get the full power and the full external rotation. So make sure they still have some mobility in their biceps anchor. And if there's a pulley injury in addition to the biceps problems, that of course strengthens the indication for biceps tenodesis, because then you solve this problem as well. And I have a few short videos of just how I do the biceps tenodesis. So of course it's a little bit easier when you have a small rotator cuff tear as well, like here. But you do the rasping of the bone underneath the tendon. And I then use all suture anchors placed in the center of the sulcus. And I use a suture presser like the one Ana-Catarina showed for DAS. And I make a lasso loop, first one in the center of the biceps. And then end up with a luggage tag. and actually do the same with the blue suture, making the same luggage tag. And as you go in and out through the same portal with this suture presser, there's no risk of soft tissue breaches. And even if it looks like a mess for a little while, it normally is a very easy technique to do the biceps tenodesis. So then I have two luggage tags, and I move one of the loose ends from, in this case, the blue to the medial side of the biceps, to have one loose end on each side before you do the final suturing. And of course, just get the same color out in the same opening to avoid some soft tissue breaches. So this is the end result, and then you move on with intra-articular biceps stenotomy in the end. So my take-home messages is that even if you find a labral injury in the MRI, you have to do a meticulously clinical examination to see if it's correlation with clinical symptoms. And then my recommendation for overhead athletes in particular would be to see if they first respond to non-surgical treatment. And remember that some of the labral injury are adaptive pathology, and that it will be hard for them to get the full external rotation and power if you tighten their biceps anchor too much. And if you choose to do surgery, there's similar outcomes after slap repair and biceps tenodesis. So that's the same messages. Thank you for your attention.
Okay. Very interesting presentation. So thank you for that. We're moving on, and now we have world-leading shoulder physiotherapists talking to us about the risk factors after the first time traumatic anterior shoulder stabilization, Margie Olds. So she's joining us from New Zealand, where now it's, I understand, morning. She has extensive international experience working in the United States, in the United Kingdom, and she even has a PhD into this topic. So I'm really curious to see what Margie is going to talk to us about that. The floor is yours, Margie.
Hi, my name is Margie Olds, and this talk is about the risk factors for recurrent shoulder instability after a first-time traumatic anterior shoulder dislocation. Shoulder instability can be classified in a number of ways, and this project was specifically about a first-time dislocation that occurred then as a result of trauma, and specifically in an anterior direction as opposed to posterior or inferior, or a combination of those directions. So specifically about anterior traumatic dislocations. And the reason we looked at those specifically was that anterior dislocations make up around 95% of all dislocations, and it's these that are typically go on to have recurrent instability. These people also have greater problems than those who dislocate in other directions. And we were interested in the risk factors that predispose or protect people to have a good outcome with conservative management, as is indicated by the smiley face, compared to the risk factors which predispose or protect people from an unsatisfactory outcome, the sad and frustrated face. We wanted to know if we could predict whether a person would have a good or unsatisfactory outcome based on some baseline risk factors. In other words, will they have a stable shoulder after a first dislocation, or will they go on to develop recurrent instability? So essentially what we wanted to know was who will suffer from recurrent instability and who will only have a single event. So in a total cohort of first-time traumatic anterior shoulder dislocations, Group 1 will have no recurrent instability, and Group 2 will go on to have recurrent instability. And so we set up a plan to look at meta-analysis of all the risk factors and then take that forward into a prospective cohort study. We published the risk factors in adults in 2015, and because they are slightly different with regards to some of the pathological factors, we also published a risk factor in children 18 years and under. The risk factors we gathered both from the meta-analysis and from clinical discussions were grouped then, as you can see on the left, and we also looked at outcome measures to measure shoulder activity, measure pain and function, fear of movement and re-injury, and quality of life. We followed people over a 12-month period and then established a predictive tool. The question most people want to know is what was recurrent instability at 1 year? And you can see in this cohort, the instability in the younger population between 16 to 25 was around 50%, where the black poles indicate no recurrence and the shaded grey poles are recurrent instability. And you see much higher levels of recurrent instability in this age group. Our prospective cohort study was conducted over the telephone and is a nationwide cohort study with the assistance of ACC here in New Zealand, which records all traumatic injuries that are suffered by people in New Zealand at that time. So we asked the baseline risk factors about the initial dislocation based on what we had learned from the meta-analyses, and then I had a team of blinded research assistants who then asked whether people had recurrent instability or not at 3, 6, 9 and 12-month time points. We published the findings of this, the univariate, in the BMJ Open Sports and Exercise Medicine. The univariate analysis would show that bony Bankart lesions being immobilized, a high Spady score, Brophy activity, a high TSK and a high WOSI score are significant for recurrent instability. And there was a trend towards significance for being in the non-dominant shoulder. Ethnicity other than New Zealand, European, Maori or Pacifica was a factor. Age 16 to 25 years was a factor, as was involvement in contact sport. So we took all these risk factors and took them through into a predictive tool with backwards stepwise regression to decide then which of these factors as a multivariate tool will come forward and be significant. And we found that we could predict recurrent instability. We've called this tool the Predicting Recurrent Instability in the Shoulder tool, and you can access this on my website. We see that ages of 16 to 25 years is significant. The presence of a bony Bankart lesion will increase your risk. The presence of shoulder dislocation on your dominant side also increases your risk, while immobilization decreases your risk, and hence the negative sign there. We also found that the Spady total and your level of kinesiophobia measured with the TSK11 also will increase your risk. We took this forward then to a second prospective cohort study to validate the tool, and we've published these findings in the Journal of Orthopedic and Sports Physical Therapy. We also have made available this tool on my website using the URL as below so that clinicians could use this tool to assist in their clinical decision making. And you can find that at margieolds.com/PRIS. What we found then in the second validation was the sensitivity of the tool is low, around 40%, but this tool has high specificity. And so while it is not good at finding who is going to have recurrent instability, it is very good at finding who is not going to have recurrent instability, with an overall accuracy of around 80%. And so in conclusion, we know that both physical and psychological factors can predict recurrent shoulder instability. Some of these factors are modifiable and should be addressed in treatment. It's also very important for all clinicians to remember that the outcomes of recurrent instability and surgery are not the same outcomes and cannot be used interchangeably. So please remember that this tool can be used to predict recurrent shoulder instability. It is not designed to predict who should have surgery and who shouldn't. And as with all work, there is ongoing work, and this is really the tip of the iceberg. We're now looking at a longer-term 10-year follow-up for recurrence. We're also looking at how we could optimize non-operative rehabilitation, knowing about these risk factors, both for physical and psychological factors. And I look forward to discussing more about this when I meet with you in Rotterdam in a few weeks. Thanks.
So it's my pleasure to introduce the next speaker, Dr. Edel Fanning. She is a shoulder specialist physiotherapist with experience of over 15 years. She is the founder of Sports Shoulder Performance Rehab. And we know lethargy is our running horse, and she will tell us what happens if lethargy fails in contact sport.
Hello, everyone. Good evening. Thank you so much for having me, SECEC and EUSSER. It's a real honour to present alongside such an esteemed panel of experts, and I've really enjoyed the talk so far. I've been asked to present a case study, so I'm going to present a case study on the management of recurrent shoulder instability in a GA football player with bilateral ladder procedures. So this is a female county Gaelic football player. I don't know if many of you are familiar of Gaelic football, kind of a mixture probably between Aussie rules maybe and kind of NFL, a kind of a bit of a mixture sport, but very much a contact sport where we see lots of dislocations. So this girl is 23 years old. She presented with recurrent right shoulder instability following bilateral ladder procedures. Her main issues now were dislocations on the right side during functional non-contact activities, such as taking off a jumper. And of course, she wanted to get back to play as soon as possible. So her background, she had an initial right side instability. It subluxed during football, quite a non-contact event, just some contact with the ball and it subluxed. She continued playing for over a year with recurrent subluxations and then subsequently underwent a right ladder in 2019. Then the left side followed suit. As soon as she went back, she had a similar low contact subluxation event on the left side and had a subsequent ladder in 2020. And then unfortunately had recurrent instability, suffered a full right dislocation, had to be relocated under gas and air, and had 3 more dislocations on the same side. And that doesn't end there. She had an ACL repair in 2017 and 2019. So she had the left and right side done. So you can see here quite a bit going on. And obviously the expectations are still as high as ever in terms of wanting to play for her county. So a little bit around what we saw initially on observation. She had some mild stretching of the scar. She was 6 out of 9 on the Baton score. In terms of range of motion, she'd full on the left, was lacking end range, flexion and abduction on the right, unsupported external rotation at 90 degrees of abduction, a lag on the right, about 90 degrees on the left, and a lag into the internal rotation, full on the left. In terms of the passive range, she had 95 external on the left, 80 into internal rotation on the right, and 75 external and 80 internal. And partly probably in that supine position, she wouldn't actively let go. So that likely wasn't true full range on that first assessment. And in terms of strength, she actually could do quite a symmetrical press up. In terms of testing the rotator cuff, there was quite a deficit through the posterior cuff in that supine position supported, as well as a deficit in the anterior cuff in the inner range. On the left, there was a posterior cuff deficit only in the inner range, but that was asymptomatic. And some other contextual factors probably to consider. Her age, she's 23 now, but when she had the ladder procedure, she would have been kind of 19, 20, so quite young, and hypermobility and genetics. Interestingly, her sister had undergone bilateral ACLs as well. So certainly looking at the ACL data there in terms of a genetic disposition to some of these, as well with the laxity and the hypermobility, these types of events, and the number of events she had. She had numerous events once she had that foot kind of partial subluxation. And bone loss, she'd no significant bone loss. And at the timing of the seasons, often these are wanting to get back to play if they're playing for the county. So the time pressures can be quite high. In terms of how I look at any of these kind of athletes, whether they're hypermobile or not, I'll go through a little bit about probably the framework that I work through and give some examples in this kind of short presentation. Often a criteria-based progression, but the baseline here is the range and motor control work, making sure she's got optimal cuff control throughout range, just like we would any patient. And you can see no matter what type of, even if you're a high-level athlete, you can certainly still have deficits in these. And I think that's always the baseline. And then often with these, you're trying to build up that strength and endurance in those early stages, even post-operatively. And then building up often some hypertrophy, particularly once the cuff is balanced into some of the deltoid muscles, as well as the rest of the body. And then often work up into some maximal strength and power and plyometrics. I think with the hypermobile patient, but again, I think with any of the kind of contact athletes, you're also thinking of that kind of shoulder literacy. Are they able to work into those flexion and abduction planes? And I think Tim Stevenson talks about this nicely. He's an S&C coach, about working into a bit like linear running, being able to change into multi-directional running for the lower limb, being able to work into those ranges in that they often need to go out in these sports into abduction and flexion, using body weight type exercises and rings, and just ensuring, rather than working in that push and pull plane when it comes to strength and conditioning, that we have challenged control in all the ranges, because the risks are incredibly high. And certainly with this lady, because she's already dislocated a number of times over the ladder J procedure, it's ensuring you have all the boxes ticked in terms of trying to help her get a successful return to sport. I'll go through a couple of these exercises. I know there's lots of physios on here today, so often they wanted some examples. And again, like the basics, like the wonderful Anju Jaggi, and I think Joe Gibson's who's on here today, and Karen Ginn, all those lovely work in terms of optimizing the control. It's the same for any type of player, getting that small stuff good, because if you haven't got the small stuff good, it's incredibly hard to build the big stuff. So we'll get Sammy to do a couple of reps there. And the big thing here we're looking for is, number one, you can see Sammy's got the thumb pointed up, so we can do it in neutral, but we really want to wind up those external rotators, get them to point that thumb up, and instantly you'll almost gain more range here. And you can see often they're struggling with no support. They'll only get to here, give them support. And finishing off there, give them maximum support to unlock that inner range. And she actually, once she got full control, at about 125 degrees external rotation, so incredible amounts of range, and it's ensuring that we can control that full range as a baseline. And then often coming into some of these with the hypermobile shoulders and the contact athletes, they love a lot of these closed chain body weight exercises, and they often challenge that end range flexion better than, say, some of your, I find anyway, better than some of the overhead press jammer type work. And this is a nice example. I often team a lot of these together depending on where they are. I'm just going to pop the legs up here. Okay, and I'm going to get them to walk backwards a little bit with the hands. Lovely. And we get them into this lovely pike position here. I'm going to get them to push through the ground and really get that nice upward rotation of the scapula. Watch out for the trunk position, that he can keep the lumbar nice and stable there. And then from there, he can come into some press positions as he's progressing on, or he can just do endurance holds. You can also externally rotate the hands if he's struggling a little bit and it's a little bit uncomfortable. So the same kind of things that you look for in your overhead press or your jammer, trying to keep that lumbar control nice. And then finishing off, we might do some of these. So you can see probably from a flex, say we're chasing that flexion plane here, how we've gone from some of that control work into the strength and then into the end range, ability to catch themselves, RFD type work. We have them ready. And I'll say, ready, set, go. He's going to catch himself in this nice end range, produce nice force there. Ready, set, go. So you can see there's often, again, just a quick snapshot, but there's a huge lot of programming that often goes into these contact athletes. And again, the hypermobiles are take even extra planning. And when it comes to return to sport testing and progression, lots of different tests out here. I'll talk through a little bit around the kind of contact athlete. Often we'll look at things like movement and stability, such as range of motion, your proprioception, thoracic spine rotation, strength and endurance, lots of different tools out there, dynamometers, isokinetics, force plates, run rep max, functional tests, the STARS test that Margie Olds has produced. So lots of different things out there. I think all with any of these tests, just make sure that we are reliable. We have a normative database to compare for. We know what we're looking for because we know interlimb asymmetry. We have to take with caution. There's always going to be some asymmetry. And then when it comes to power, things like some of the counter movement push-ups, press jumps, seated med ball throw, and then the psychological and self-reported measures, which we'll all be familiar with. And then return to sport loads performance, consider testing our athletes under fatigue, because they're certainly at risk, tend to be in the later half of the games. And again, with all of this, it's a huge continuum. It's not just the shoulders. There's often a lot of conditioning going on for the rest of the body, because often they're going back to these quite change of direction sports and the risk of injury elsewhere. I think a couple of reflections for the future, because they're an extremely difficult cohort, the hypermobile contact athlete, is early development and preparation. And we know from the ACLs, improving training, it looks like it's starting to improving training and preparation for young female athletes, reduces ACL injury risk. Is there a role for that in the shoulders? Return to sport criteria and guidelines. I think probably not establishing more but better criteria that's very specific to the athletes and the sport, and particularly when it comes to the hypermobile shoulder. I'm not sure at the moment what we have out there is good enough for testing these, and probably still needs to be continued to develop and looked at. And then the long-term investment over quick fixes, things like equal resources for girls' development to close the gender gap. It's the same certainly here in Ireland. Say, for example, your female rugby players have less resources than the male rugby players, and that hugely affects when you're starting to program these. They're often working a full-time job alongside them, so lots of things to have a think about. Thank you very much.
Well, thank you, Edel. I think I'm happy that I'm a surgeon now and not a physiotherapist, because your job seems much more complicated than ours.
Oh, I don't know, but I think we all have a huge challenge, haven't we, in some of these athletes? Incredibly
Well, I agree.
difficult.
That's probably most of us we would not like to treat a patient that already failed the Latarjet. And yeah, it was great talk, though some parts are probably very technical. Thank you very much. So we'll move to the questions. I mean, if everybody has any questions, there is one question on the Q&A here, and I'm gonna raise it up to all faculty probably. It says, what are the key points for patient education prior to operation and conservative treatment? What would you recommend? If anyone wants to answer that. So basically, I think it's what would you advise your patients prior to the operation? How do you sell the operation or the conservative treatment, and what's your approach on that?
Was the question for a particular procedure? Was it for Bankart or was it for SLAP or?
Well, I think it was mainly in the beginning of the talk, so I think it was referred to the Bankart or non-bony stabilization. It doesn't say.
It was just after Bart's presentation, so I don't know if maybe Bart would like to answer that, about how he does it with the remplissage and combined with Bankart, how he advises his patients.
Well, I think the most important thing is with all these kind of procedures, more like it's not a quick fix. The patients need to invest their time and effort in going into an extensive rehab before they get finally back to daily life, but even further on. And I know we are going to very short immobilization for Latarjet maybe, but the soft tissue repairs definitely need their time to get up to sporting level again. So I think that is important to explain and to engage patient in their rehab.
You have done great extensive research on what to choose and how to choose, differentiate Bankart, Latarjet, which patients. what do you consider for conservative treatment, or which patient would you select and say, okay, these guys I will try?
Well, if they don't want to embark on surgery, I guess that's important as well. Again, engagement, but well, I have a very low threshold, I think, for surgery, but that's maybe because they come into my room and they want to discuss. But there are some people that say, hey, my shoulder feels fine, I want to go. And it depends on what kind of type. The sports, well, again, I try to discuss with the patient and explain them who has a high risk, who has a lower risk of redislocation.
Thank you.
Anju has a question.
Yes, thank you, Jag. Apologies, for some reason I don't seem to be able to type into the Q&A. Margie, I had a question with regards to immobilization, because that is a predictive factor for recurrence. In your opinion then, is there an optimum time that people should be immobilizing their shoulder following a first-time dislocation?
Morning, Anju. Thank you for your question. It's really nice to see you. Our research showed that if you are immobilized or not, dichotomously, then that decreases your risk. We weren't powered to look across time, whether how long you were immobilized for. We know from other systematic reviews that there really is no difference, 3 weeks or not. My clinical practice is to immobilize for comfort. I think it's very important that they are immobilized, but we don't really have any good evidence how long. I think this population is very heterogeneous, aren't they? They have different size lesions, different types of lesions. Some have a Hill-Sachs, some don't. And so my clinical practice is to immobilize for pain and comfort. We know that they need some immobilization, but we really don't know how long. And I'm not sure we ever will do at an individual case level. So I immobilize for pain and comfort, but I don't, there's no set rule, I think.
Okay, that's great and reassuring, because it means that we're still following good practice. Okay, thanks.
Okay.
I have a question to Anna. Beautiful videos you showed of the DAS, and then you recommended that we should do an anterior capsule release and then go outside again in the subacromial space and then release the transverse. Is that the way you said? Yeah.
No.
So yeah.
Almost. You were almost there. So
Yeah.
we never go subacromial.
Okay.
So to release the transfer, you're viewing from your posterior portal as well. You just elevate the upper limb a little bit more, so you can have access over the groove to the more inferior groove and to all the transverse. So it's not, this is a very common question that we get. So how do you look through the groove? But if you try it in your next patient just to see, you will see that you will be able to do it. From the soft spot, you just place your scope over the biceps, and then you flex the elbow a little bit more, and then you look down, and you're going to be able to see the groove and the transverse ligament. So you never go subacromial. We do everything in this technique from viewing from the same portal, which allow us to save a lot of time. We just change portals at the end just to check, just to view the final result, just for this purpose.
Thank you.
You're welcome.
With a 30-degree scope, Anna.
Yes, 30-degree scope. That's it.
Okay.
No 70s.
I must say thank you to all the speakers, to the moderators, and now we're going to go to the section 2 of our webinar. So over to Joydeep and Anju.
Thanks for that excellent first part, which was a great highlight of the value of both the surgical and the physiotherapy side. And I think we've got a similar aspect on this half as well. So I'd like to introduce Carlos Cobiella, who's a fellow shoulder colleague consultant with me in London. And he trained in Madrid, but did his shoulder training at the Royal National Hospital in Stanmore, and is a consultant orthopedic surgeon both at University College Hospital in London, and also is the upper limb lead for the Institute of Sports and Exercise Medicine and Health at UCL. And he's got extensive experience of treating high-level athletes in terms of sports injuries. And he's going to talk about an update on bony procedures of the arthroscopic bone block.
Good evening, everyone. Thank you very much for attending this excellent webinar on updates in shoulder instability. I'm Carlos Cobiella from sunny, literally sunny London. I would like to thank the organizers for the invitation and for asking me to talk about the arthroscopic management of bone defects. Why do we need to do a bony procedure? When we started doing arthroscopic Bankart repairs in the late 90s, we were very satisfied that we had cracked the instability problem. We now had an operation we could reproducibly do that would stop it. And the results were great, or were they? In the early 2000s, there were a large number of publications that reported a significant number of failures, and these seemed to be associated with bony defects. Those defects can be localized in either the anterior inferior glenoid, what's known as a bony Bankart, or a heel sacs that would be significant enough to cause engagement. The concept of engagement is when the defect in the humeral head reaches the front of the glenoid and falls off the cliff, so to speak. This is something that we can objectively measure by using Itoi's method of calculating the glenoid track. If a defect is on track, we can safely do a soft tissue procedure. If it is off track, it will require bony augmentation. Well, that's one way of doing it. I'm not that scientific and actually prefer a pragmatic method of looking at the joint during my arthroscopy in a bed chair position without traction, with the arm held in anatomical range of motion and looking to see if there is actual engagement. It's not entirely accurate, but it gives me a very good idea of which defects are significant enough that I need to augment. So once we identified the problem, we looked for a solution and we looked at what we had available. And the bony procedure we had available at the time was the Latarjet procedure, described by Michel Latarjet in the 1950s, which is actually a very good procedure that is still carried out today. That's an excellent endorsement for an operation, 70 years of use. In many cases, it's done as a primary procedure. However, and the mechanism by which it works is what we know as a triple locking, increasing the glenoid stock with the coracoid bone block, repairing the capsule, and relying on the dynamic sling, which is formed when you relocate the conjoint tendon anteriorly in the glenohumeral joint. I do, however, have significant objections to it, and I had them at the time. It's a non-anatomical procedure where the subscapularis is violated, in many cases resulting in damage to it, with a high rate of complications compared to other procedures. My main objection, however, is got to do with screws. And if you look at this nice little video that was running a second ago, you can see what happens when the coracoid resorbs and you have metal in contact with the humeral head. A level of scraping is inevitable. And although it doesn't appear to be very significant in this AP view, if you look at the axial, you realize that you have had a complication of an operation in a young athletic person, which will now require a shoulder replacement. That, to me, is not acceptable. So we started looking at different ways of trying to solve the problem. In my mind, if I had a bony problem due to defect in the glenoid, if I restored the bone stock in the glenoid, I would then convert it into a purely soft tissue problem. And that can be achieved by doing the operation that Eden and Hibbinette described at the beginning of the last century, and was then modified into various different techniques that were available to all of us. The one that I liked the most was the one described by Hatcham in Barcelona, where he would use two tapes going through the glenoid and into the bone block. This would be done through the rotator interval without any damage to the subscapularis, and then those two tapes would be interlocked and tensioned, providing a very good fixation of the glenoid, and more importantly, no metal. This is the kind of results that you can expect. As you can see, there's been good union of the block anteriorly. You can see where the anchors for the labral repair have been placed in the native glenoid. In many cases, you will see much more bone loss than that. Resorption is called. I prefer the term remodeling. Whatever is loaded will remain, according to Wolff's law, and what's not needed, if it goes, it goes. It's not needed. So that is really what I liked about it. And this was then the way I started thinking about instability, soft tissue problems, labral repair, bony problems. Well, if I had good soft tissue, I would do a bone block and a labral repair on top. If the soft tissues were poor, I would still do a Latarjet. And that changed the way I was operating, in the sense that from going to a high percentage of Bankart and a reasonably low percentage of Latarjets, I reduced the number of Bankarts I was doing and increasing the number of bone blocks. The reason being, I had a lower threshold to do a bony procedure if I was in doubt, as the rate of complications was lower. That was what I saw when I reviewed my cases, and the rate of complications was actually similar to what it was in the Bankart. It's not a similar procedure. It's a much more difficult procedure. And in reality, what it is a much longer procedure, as there's many steps involved. But the rate of complication remained very similar. So this is the way I was thinking about instability then. Soft tissue problem, Bankart repair, bony problem in the glenoid, good soft tissue bone block, poor soft tissue Latarjet. When looking at the Hill-Sachs lesion, if it was purely the Hill-Sachs side, addressing the glenoid would not necessarily make any difference, because as it's not being loaded, the bone block would resorb quite readily. So that started making the remplissage a much more popular procedure. This remplissage is starting to change the way I think about instability again. And the concept here is critical bone loss. If the defect is higher than critical, then a bone block seems like a good idea. Augment the bone stock and then do a labral repair. If, however, the defect is less than what we consider critical, then a remplissage has a very similar result to Latarjets, even in contact sports. And so that is something that is, again, changing a little bit my practice. On the soft tissue side, Philippe Collin's and Alex Lederman's DAS has changed a little bit the way I look at those type 1/2 hyperlax patients, where I may add a long head of biceps sling. Of course, the issue here and what we need to solve is what is critical bone loss. When we started looking at this term, it was described as 20 to 25%. Then some studies described 17%. Some actually decided that it was less than that. And then when we reviewed it, we realized that we didn't have an agreement. And in actual fact, is critical what we should be looking at, or do subcritical lesions also cause problems? Well, that's food for thought and for further development in the future. Thank you very much.
Thank you, Carlos. Thank you for an excellent talk introducing in terms of bone loss and what to use. I'd like to now introduce Professor Olivier Verborgt from Antwerp, who's a shoulder surgeon, head of the Orthopaedic Centre in Antwerp, and also is the consultant in the Department of Orthopaedic Surgery and Traumatology in the University of Antwerp, and also professor in the Faculty of Medicine and Health Science at the University of Antwerp. He's also at the present time the president of the Belgium Shoulder and Elbow Society and has been president of the Belgian Association for Orthopaedic and Traumatology, and has also an extensive experience, like Carlos, in treating sporting injuries and shoulder injuries. So, Olivier, thank you very much for talking about lateral surgery.
All right, thank you very much, Joydeep. Good evening, everybody. So my talk will be a little bit overlapping, but also build further on the previous talks. We have heard that in the last decades or so, the discussion between soft tissue and bone block procedures as a treatment for shoulder instability have been going on back and forth. And traditionally, bone blocks have only been used for critical bone loss. And we have learned quite a lot, and I refer to the previous speakers, what critical bone loss means and what it means now compared to what it meant 10 years ago. It seems like critical bone loss now is more than 25% of glenoid bone loss in an on-track lesion, but in an off-track lesion, it becomes much smaller, and the indication for bone block procedures are much higher. I would put the statement a little bit more specific, and I open the discussion for this, but I think it's not only about bone loss. When you treat instability patients and specifically athletes, it's much more about a multifactorial approach, even patient-specific parameters, but also speaking about the lesion and the tissue itself. If you repair the shoulder, will it be stable enough to keep it in place after your surgery? This is the basic thing that you have to ask yourself. And if you ask yourself that in specific questions or specific patients, you will end up with a bone block as the result of your equation quite a bit. Specifically, if you're talking about athletes and athletes factors, you have to consider whether it's a contact or a non-contact patient, whether it's an overhead or a non-overhead patient, what is the position of the player or the role in a team? How much time do you have? Is it an in-season or an out-season discussion? What is the timing in the career? What are the specific upcoming competitions, and what are the implications to their career length? And this can also influence your decision when to operate and which technique you want to use. There's usually a high pressure on these athletes. There are financial implications, but on the other hand, they usually have top rehabilitation and support resources, and they can come back from a very difficult situation to where they started off. And this is one of my patients that I had to decide on, and I think is the best summary of the last couple of slides. It's a 22-year-old Olympic gold medalist gymnast that had one dislocation or subluxation 16 months before the Paris Olympics, with some minor soft tissue lesions, and the question when or what to do with this shoulder. I will come back to that later. The reason why I'm such a big fan of the lateral procedure is this one of other than that is this landmark paper that was been published in the Mayo Clinic a long time ago, where biomechanically it has been proven that the lateral procedure makes your shoulder 300% more stable than in a shoulder where there's a Bankart lesion. And this is so important, and this is why I call it the Ferrari of the shoulder instability procedure, because it outperforms any other procedure. The question, of course, is, do you always need this procedure in all your patients, or do you also settle with less stable reconstructions? Why should you only treat the glenoid? It has been shown that the Laderger effectively converts off-track lesions to on-track despite graft modeling. So no need to treat the humeral site. There are lower recurrences than remplissages in contact athletes, revisions, and patients even with more than 10 degrees, 10% of glenoid bone loss. The remplissage results in a reduced external rotation if you do them in larger Hill-Sachs lesion. They feel subjectively less stable, and in larger lesions, in Hill-Sachs lesions, remplissage increases, has an increased recurrence to 12%. And this is why a Laderger is better than treating the humeral site in combination with a Bankart, for example. For me, the only exception to touch the humeral site is when there's a significant humeral bone loss of more than 30% of diameter of a humeral head, which is rare cases, epilepsy, where we use fresh frozen osteochondral allograft reconstructions to fill the defect in the humeral head. This is a typical patient that I think most of us will agree on. A competitive football player, multiple dislocations, contact athlete, bipolar bone os, an off-track Hill-Sachs lesion, Laderger standard technique with an early return to play and level with no recurrence or apprehension. This may be a little bit more open to discussion. First-time dislocation, an on-track Hill-Sachs lesion, not a lot of important soft tissue lesions, a small Hill-Sachs, but still we went for a Laderger procedure due to his type of sports and the level of sports as well, with a good return to play and no recurrence or apprehension in the end. Bone block procedures have now been shown also to work not only in important bone loss, but also in patients without important bone loss. Patients where you think that the soft tissues will not be good enough if you reconstruct them to hold the shoulder in place. This is true for very young patients. This is true for ALPSA lesions. This is true for patients with hyperlaxity. And this has been shown also for patients involved in contact sports. There are numerous reports out there. It's also been our experience that the return to competition with an open Laderger, for example, in soccer players, is high. This is an older Jill Walsh paper, 96 return to competition. And even also in overhead athletes, handball players, Matthias Sumstein and his team reported on 80% of return to the highest competition level. If you compare them to just Bankart alone, for example, Australian football, the recurrence for Bankart is much higher than when you do a Laderger. Of course, you have to be aware of your technique. You have to be aware of poor technique and complications that are associated with this. This is a patient, a kickboxer, professional kickboxer that was treated with a Laderger and afterwards was sent to us. And of course, this is a terrible complication with a musculocutaneous nerve lesion after this surgery. For a kickboxer that cannot give you an uppercut, that's a big problem. And this is, of course, an important failure. Also, the screw positioning and the use of screws can be a danger if you don't put them well, as in this patient, a kayak a rower, 23-year-old male with a poor surgical technique. The bone block is too lateral. The screws are too much in retroversion, and the heads of the screws are sticking out. And this can go very fast and make a terrible damage to the joint in a very short period of time. So, of course, we all agree that this is not the idea of instability surgery, and this should be avoided at all times. Therefore, people have looked for alternatives for screw fixation. I think that's a reasonable thing to do, whether you use buttons or even suture cerclage has been shown to be probably avoiding screw complications. On the other hand, I think it also compromises the fixation of the bone block, and it's your choice whether you rather choose this type of fixation or go back to standard screws. I still prefer the original Jill Walsh technique with a subscap split, having the advantage of the sling effect of the conjoint tendon, have bone-to-bone healing with proven a good return to play, and a very important track record in a high level of patients. Of course, the surgical technique has to be right. The exposure of your anterior glim should be good. I usually use a recreator on the medial side, Fukuda in the joints, and then a Steinman pin to retract the subscapularis superiorly. I place the first pin 6 millimeters away from the articular cartilage. I don't use guides for that. I just use the simple calculation. So the inferior drill hole is 6 millimeters away from the articular cartilage. In the left shoulder, this should be at about 7 o'clock. And then the superior screw should be parallel to the first one. They should both be parallel to the articular surface. Whenever you go more than 30 degrees of retroversion, you can hit the suprascapular nerve. And of course, that is not the idea. But if you do it like this and you have the position and the exposure like this, you'll be out of trouble. And then the problems of the screws are anecdotal. If you put them right, less than 1% of the screws needs to be removed at some point. I'll come back to my favorite example for la Latarjet. And also, if you ask me, will you lose mobility? Will you lose strength because of the type of the surgery? So she had a second dislocation a few months later after the first one. She was then 9 months before the Paris Olympics. We did a classic open Latarjet with bony healing at 3 months, returned to play at 6 months, and she was back in the final in Paris at 9 months. This, of course, is not only the surgery, it's also the extraordinary character of the patients and the rehabilitation team. But I think it's the best way to prove, and I rest my case with this one. Hope to see you all in Rotterdam.
Thank you, Olivier, for an excellent talk and a fascinating proponent for the Latarjet. Thank you very much. I'd just like to go to our last surgical speaker for this session, who's Professor Charles Getz, who's Professor of Orthopedic Surgery at the Sidney Kimmel Medical School in Jefferson University in Philadelphia, and was also in the board of directors for the Rothman Orthopedics, which is another fantastic institution in that city. And he's going to talk to us about posterior instability. Thank you very much, Charles.
Thank you for inviting me to give this talk on posterior shoulder instability. I'm Charlie Getz from Philadelphia. These are my disclosures. Posterior shoulder instability is often overlooked when talking about shoulder instability, especially compared to anterior shoulder instability. However, we do understand that this is an increasingly recognized etiology of shoulder pain, particularly in the younger athletic population. So we're going to assume that you're going to do a thorough history and examination of these patients, and we're going to focus mainly on the instability tests and instability findings on my examination maneuvers. We're also going to assume you're going to get good radiographs looking at bony injuries that may be associated with this pathology. The mechanism of injury for posterior instability is typically posterior force directed on a forward flexed arm, falls from height. Offensive linemen for American football are commonly put in this position and are a frequent mechanism of injury for patients that present to me. The physical examination maneuvers that try to reproduce this position are the best ones for diagnosing posterior instability. One would be the posterior stress test, as demonstrated on the right-hand side, where you force the humeral head over the posterior labrum, see if it reproduces the patient's pain. Then on the left-hand side, there's demonstration of the Kim test, which is similar but in a slightly elevated position, and a jerk test, which is more dynamic, taking the head, pushing it out, and seeing if it reduces and reproduces the patient's pain. We should be familiar with other signs of instability and other types of testing: generalized laxity, a Gagey sign for multidirectional instability, anterior shoulder testing, and then show me test, which is a form of evaluation of patients with scapular dyskinesia. Traditionally, we looked at this as traumatic versus atraumatic, acute versus recurrent. Now we have a better unified system as represented from the charity group in Berlin, the ABC categories. And I think that this is going to be important for us to all start speaking the same language to be able to compare apples to apples and oranges to oranges in the future. So the A is for acute, which is traumatic. We have subluxation versus dislocation. The instability from a subluxation typically is from athletic type of injuries. In my presentation, sometimes it's work injuries. The younger, more athletic populations, particularly with posterior labral tears, bony injuries, have a very high risk of failing non-operative treatment. So I think it's ideal to identify those immediately with an MRI or MRI arthrogram, depending on how acute we can get those images. A dislocation, if it presents in a dislocated position, we have to reduce it. Under a week, I think you can usually get it done with sedation. After a week, it gets harder and harder to get back in, and oftentimes requires an open dislocation. If we can get it reduced, the A2s generally do well in a lower demand population, slinging them in external rotation for 3 weeks, preventing them from going behind their back for 6. With some physiotherapy, they're usually back to their pre-existing condition 3 to 4 months from their injury. If we can't get it to stay reduced, we have to do something with this Hill-Sachs lesion, the reverse Hill-Sachs lesion, which is typically the problem. So we can disimpact it to bring it back out to its level. We can graft it with bone or partially replace it. We can transfer the tibial tubercle into that defect, or we can transfer the subscap into the defect, making it extra-articular. This is my preferred technique in an acute setting, as I think it's quick, easy, and reproducible. And finally, hemiarthroplasty, when we start getting the humeral head lesions over 40%, should be on the consideration as some of these other transfers and partial replacements and grafting just seem to not be enough. For A2s, low-risk patients do well with physiotherapy. The same group of high-risk patients in the younger athletic population generally do not do as well non-operatively when you could think about doing surgery on an earlier basis. Generally, when these people fail, though, they fail with pain, not recurrent instability, as is seen in anterior shoulder instability. Arthroscopic posterior soft tissue repairs are the mainstay, posterior labral repairs, and most of the time the bone is there. So if you get to them acutely, we can usually tolerate a fair amount of bone loss posteriorly, but in acute setting, usually the bone's there, and if you repair it, it reconstitutes, and you don't have to worry about doing some sort of bone grafting procedure. For recurrent instability, or the B group, they break down into neuromuscular, or I would say the dyskinesia group, or the B1s. The B2s are a structural group, and you can see the list down below of all the different structural things that you may encounter for treating these folks. Generally, these patients are going to present with symptoms of pain. Pain is their issue, particularly using the arm in a forward flex position in front of their body. I think of anterior instability as being abduction pain and instability, and posterior instability is more forward flexed instability. Many times these injuries happened many years ago. They were playing sports as a teenager, had an injury, never really saw treatment, and then had a period of sedentary lifestyle, and as they started to increase, they started getting shoulder pain again. Very common scenario that brings people in to see me. There's also a history of people that do a lot of repetitive motions, putting their hands in front of them, dropping onto their hands, pushing their humeruses out the back. That leads to this problem as well. Similar imaging with an MRI arthrogram this time, or CT scan if there's bony injuries that are more going to be what you have to address. The B1 groups, so no structural damage on the MRI. You think this is more of a dyskinesia problem, a muscular control problem, and we'll see a nice demonstration of that in a little bit. Do very well with physical therapy, and this is where the pacemaker that is going to be demonstrated later can be helpful to retrain that dyskinesia patient. So questions that I still have in the B1 patients are, is that scapular mechanics really the primary issue always, or could there be an associated labral or structural problem that we just haven't really learned to define? And is surgery ever really necessary? And if so, are there certain patients that we should be thinking about surgery sooner for? Again, just not sure we know enough about these patients at this point. The B2s are the recurrent instability to a structural mechanical problem, have some tendencies to occur with people that have higher or flatter acromions. If it's more posterior, it acts as a physical block to posterior instability. Glenoid retroversion has been associated with glenoid instability as well. Posterior instability, as we get above 15 and 16 degrees of retroversion. The high-risk patients, as we've said multiple times, are people with bony or labral injuries, tend to do poorly with non-operative treatment. Patients that do not tend to have this and have a pure capsular laxity tend to do better. And so we would recommend at least 2 to 3 months of therapy. If they have a labral tear, we fix it arthroscopically these days. If they fail physical therapy from the B2 with just a capsular laxity, this is one where we do application arthroscopically as well. And I do think it's important to mention it's arthroscopic procedures, as opposed to anterior, where open procedures have actually done pretty well. They've not done as well posteriorly, and the arthroscopic approach is a big improvement with return of patients to play and to decrease their recurrent instability. If we're going to do that posterior capsular plication, please combine it with anchors, as that's been shown to be more effective. Return to play is over 90% in multiple studies, except for in throwers, which is closer to 80%. At one point, the biomechanics showed that there would be there had to be an injury to the rotator interval to have posterior instability, and we closed the rotator interval. I don't think that data is played out clinically. And in fact, by closing the rotator interval, you restrict external rotation. If you do that in a thrower, I can guarantee they're not returning to throw. And so I don't think the data supports us closing rotator interval as part of a posterior instability surgery. Unanswered questions for B2s: how much bone loss, and do we need a glenoid tract calculation to start thinking about when to do something for the humeral head? Is capsular laxity in those B2s the same as labral tear patients? I don't think that they really are, and maybe they should be subdivided out. And what's the best treatment for cartilage injuries? Do we just cover it up with labrum, which is the PAX, or do some sort of micrografting? And this is a demonstration of the PAX procedure from the charity group's EFORT report. Static subluxation was reported by Gerber many years ago. He defined it, didn't really give us much information on what to do with it. This has been revisited by a charity group that shows this as a pre-arthritic condition, and a very challenging group, as it seems like everything that we do fails after some point. C2s is a mixed bag of bony problems with subluxation. C1s, everything can work for a little bit: labral repairs, PAX procedures. Attempts at glenoid diversion correction don't seem to be worth the risk, and most people are not advocating for that. And then, is there some sort of dynamic restoration that we need? So by transferring some of the posterior acromion along with some deltoid, does that provide enough dynamic force to help recenter the head? I think that's likely going to pan out to be the best operation, but more data needs to be seen. The C2s is a mixed bag. You have to consider bone and soft tissue repairs, again, transfers, and shoulder replacement. So final thoughts: we have a better understanding of the pathology that cause shoulder instability. I think we have the increasing recognition with better treatment options. We need to use a uniform terminology so we're all speaking the same language, and we'll have a continued evaluation to improve our treatment options. Thank you, and I hope you consider joining us in Vancouver for the ICSCS 16th edition.
Thank you very much, Charles, for a fascinating talk, and I think an area where we're learning a lot more knowledge than we had in the past.
Thanks, Joydeep. I've got great pleasure now in introducing our next speaker, who is Solenn Gain. She's a French physiotherapist who specialises in shoulder rehabilitation. She's the Vice President of the French Society of Shoulder Physiotherapy. She's also the chair of the EUSSER Network Committee, and then she's the EUSSER French National Delegate and EUSSER representative for SECEC. Really looking forward to your talk, Solenn, because you're going to talk us through posterior instability with scapular dyskinesis. So over to you.
Thank you, Anju. Hello, everyone, and thank you very much, Jagwant, for inviting me tonight to talk at this joint SECEC-EUSSER webinar. I'm very pleased to talk about posterior shoulder instability with scapular dyskinesia. This is a subject that we have studied a lot with Philippe Collin, with whom I am working. I'm going to present a clinical case. This is a clinical case about a woman with a functional posterior shoulder instability. According to Moderators classification, it's a non-controllable and positional posterior instability, B1, functional dynamic posterior instability. So she's a woman of 26 years old, she's nursed in an hospital, and she has a non-voluntary posterior instability already present for several years, but it was less significant. She had experienced increased pain and functional discomfort at work with significant limitation of active elevation. She has kinesiophobia related to several subluxation during active movement. But she has also high expectation for rehabilitation and no depression. Here you can see the videos of her active elevation. You can observe the limitation of the motion, the scapular dyskinesia, and the posterior instability with subluxation. In the photo on the right, we can see the difference in active range of motion in elevation compared to the opposite side. She also has generalized hyperlaxity. If we now focus on the kinematics of the scapula in upward rotation, we can see that this is a reverse kinesia. Indeed, we can see the scapula moving in downward rotation at the beginning of the movement instead of moving in upward rotation. This is associated with inferior angle winging and posterior instability. The scapular reflection test was positive, and as is also the scapular reflection test modified during movement. This is a type D of scapular dyskinesia with posterior instability according to the classification we developed with Philippe Collin. In scientific literature, and particularly in these articles, a link seems to be found between dyskinesia and posterior instability. Margie Olds' article also mentions the importance of the assessment of scapular control and strength. The clinical examination for this patient shows an hypertonia of anterior muscles and an active contraction of back legs at the start of the movement, and hyperactivity of the upward rotation muscles, serratus anterior and trapezius. There was also a lack of mobility of thoracic spine and clavicular. The most important thing is to see that the problem comes from the brain. This is a neuromotor incoordination. There were no neurological damage. So the aim of the rehabilitation is to normalize muscle activation patterns and to reactivate muscles of upward rotation, trapezius, serratus anterior, and the posterior cuff, external rotators, like we can see in the systematic review of Anju Jaggi. But it's not only about scapula. Because you can see here in that video that the patient have difficulty standing on one foot. The difficulty increased significantly when she stands on tiptoes and even more when she raises her arms. These videos clearly shows the problem of imbalance and lack of motor coordination between the different segments of the kinetic chain. Rehabilitation will therefore be necessary to retrain each link in the kinetic chain. And this article suggests that the scapula could be the weak link in the kinetic chain in posterior shoulder instability. The kinetic chain is very important in rehabilitation. Working with the kinetic chain increases activation of scapular muscles by using the lower limb or trunk, as described in literature by Jeremy Lewis and Joydeep Sinha. Working with the whole body is very important to activate motor pattern. So it is really about neuromotor rehabilitation. We have to train the brain and activate motor patterns. Here are some examples of what can be done in neuromotor rehabilitation. We can use the two rubber lines symmetrically, use kinetic chain, work on endurance, speed. We can use, for example, metronome. We can use also vision. And it's important to focus the patient's attention on the hand or grabbing activities. The shoulder is there to serve the hand. We can use external focus. At first, the goal was to restore normal start of movement and increase elevation and scapular upward rotation. Lynn Watson demonstrates some very interesting exercises for this. Here, the scapular resistance band enhances scapular motor recruitment. As the patient had significant balance issues, we worked in seated position at first to remove the lower limb component. We then work on each segment of the kinetic chain, and the tape strips enable proprioceptive feedback. In case of functional posterior instability, it's very important to work on the posterior rotator cuff muscles together with the scapular muscles. As described in the literature by Lynn Watson, Margie Olds, or Anju Jaggi. These videos show exercises to straighten the posterior rotator cuff muscles, scapular muscles, and posterior deltoid. We can use both arm in the exercises and kinetic chain. The shoulder pacemaker was also used to increase the contraction of external rotators and scapular muscles during elevation movement. Working with an external focus enables the patient to concentrate on the hand rather than the shoulder, as the shoulder movements are automatic and the shoulder is saving the hand. This is also found in the pain exercise. Here are the results for the rehabilitation for this patient. She has regained better mobility in active elevation without posterior instability. She has regained greater comfort in her professional life. However, it's quite difficult for her to perform more physical activities involving carrying loads. In conclusion, when dealing with functional posterior shoulder instability, it seems to be important to assess scapular kinematics, evaluate and work with the kinetic chain, do strengthening for serratus anterior, trapezius, and posterior cuff during movement. Neuromotor rehabilitation is very important to activate motor patterns. And remember, we have to train the brain. Thank you very much for your attention.
Thank you, Solenn. That was brilliant.
You can join us at EUSSER and follow us on LinkedIn, EUSSER, Instagram, Facebook, X. And you can come also to Rotterdam Congress for the Congress of the EUSSER and the SECEC. Bye.
Goodbye. Thank you for the plug. And yes, we hope to see many people in Rotterdam later this year. So last but not least, but I would like to introduce our last speaker, and then we can open to questions. I'm really looking forward to listening to Matteo Mantovani. This is someone who's really developed and had a passion in integrating technology solutions with rehabilitation, kinematics, and analysis of movement. And Matteo, we're really looking forward to listening about the pacemaker and its benefits in shoulder instability. So over to you.
Thank you for the kind introduction, and thank you for giving me the opportunity of presenting this evening, or maybe I should say tonight. So I will try to be quick and effective because of the late time in the day, but let me go quick through the presentation. I think that we already have covered some of the preliminary slides that I put in my presentation, so I will be very quick on this. So following this publication by Moderators, so we are trying to address the polar type 3, so that's actually related to an imbalance. So, and this imbalance may be due to both muscle hyperactivity or hypoactivity, and is usually not related to structural defect. So this has already been shown by the previous speaker. So the classification, the ABC classification provided still from Moderators, that differentiate between positional and non-positional, and that provide two different categories in each side, controllable and not controllable. So, but we are focused a lot on kinematics, as the previous speaker just said, and we care a lot about, tracking scapular movement, and so that's what we have developed as a method to assess the scapular activity. So basically, what we do, we are tracking the three main rotational degree of freedom of the scapula, and we track also the coordination between scapula and humerus. And actually, this is particularly relevant to track scapular tilt, protraction, retraction, and upward, downward rotation. So most of my presentation will be based on the findings, because actually I will provide a classification of three different patterns that we found associated with scapular posterior functional instability. So there's a lot of publication about the validity and the the accuracy of the methods. I won't spend time much on this, But if we go into the literature, so we find also, more or less same kind of confirmation. So I mean, there are authors that stress the importance of the latissimus dorsi as well, but also motor control, as being correctly said by the previous speaker, is very and extremely important. And is also, I would like also to stress the importance of sensory feedback in fine-tuning the movement dynamically. So in order to fine-tune the dynamic imbalance. That said, we had a chance to see on some cases something like this, and of course this has been obtained by tracking the scapula versus the humerus versus the thorax. And actually what we have seen in posterior functional instability in subjects like this is that when you have an excess of retroversion of the humeral head or intrarotation of the humeral head compared to a lack of activity of the scapula, you may enhance the mismatch between humeral head and glenoid fossa, and that's what it has been shown by the yellow arrow in this figure compared to the contralateral side, which is on the upper right corner. And basically, we see that when this angle enhances, we have the unstable happening, and so we have the popping in the shoulder. So basically, this was very visible. So actually, and we need to understand who are the intrarotator in this case responsible for this. Basically, the key concept around the pacemaker are concepts related to the motion activated stimulation and are all based on functionalization. So basically, as more or less already being presented, so we set a name because actually it's very important to have a complete involvement of the subject in order to reach the retraining of the motor pattern, and we need to be able to recreate the automatism. So, and actually the automatism can be created through the aim and the focus that we do ask them to keep. And of course, reward is extremely important to consolidate the learning. And so the key factor from a technological standpoint, from a technical standpoint, are related to the fact that the intensity of stimulation is dynamically controlled along the range of motion in the attempt of mimicking what's happened in healthy subjects. And so I would like also to stress still more the importance of the multisensorial afferences to reinforce the learning in order to be able to have the patient controlling their shoulder autonomously without the need of any external device. So the equilibrium we are trying to set here is between feed forward and biofeedback, because actually both are embedded into this method, because actually the feed forward try to anticipate and correct before the arm goes to the next step, to the next position, while biofeedback is extremely important to enhance proprioceptivity and facilitate the learning and the restoring of a proper motor pattern. There are studies showing the long-term effects. I won't spend time on this, but actually, because actually it's very important not just to be able to establish if this corrects the dysfunction, but also if this correction remains in time. There's this longitudinal study, and there's also another more recent RCT study compare traditional versus traditional and pacemaker add-on. And actually, this study have proven the efficacy of the treatment, not just in the short term, but also in the mid to long term. But let's move to the kind of classification we have been able to collect based on the use of a pacemaker on posterior shoulder instability, because they are not all the same, always the same, and actually the pattern could be significantly different, even if they look from externally all the same. But actually, we created 3 different categories, and actually based on where we do place the electrode. So the figure number 1 shows what has been historically published and presented, but the central figure shows a different placement, more focus on the medial wall of the scapula in order to stabilize. And actually this, I think that the incidence of this category is exactly the same of the first one. And then there's a third and more difficult set or class of posterior shoulder instability, which needs an addition of multiple channels, because actually we need to introduce also the serratus anterior as main stabilizer. So just to present one case for each of these three categories, this is the category number one, so the one that has been published extensively and probably presented in by many authors in many conferences and papers as well. And so just to show that actually the involvement of the cuff in this specific type of patient is extremely important to stabilize and reduce probably the intra-rotation responsible for that unstable pattern that was shown in the previous slide. So we described kinematically this kind of patient, and basically I think that the degree of freedom which shows more clearly the unstable pattern is protraction retraction with design an H shape basically, and but as we see, tilt, scapular tilt is, well, actually not optimal, but let's say not bad. And while still the upward downward rotation is not really affected. In this second group, instead, we see that the previous electrode position was not working at all. So the importance of resetting the electrodes on the medial wall actually can help stabilize the patient and actually can provide a quick return to a complete function and to a complete return to sport. But if we have a close look at the kinematics, we do see that there's a completely different pattern, and actually look at the upward rotation, how difficult it is at around 90 degrees to still improve the upward rotation of the scapula in this patient, and actually look at the protraction retraction curves in this magenta line, which you see are very much dispersed, and actually they have an inverted shape, which actually completely conflict with what we found normally. And this is another important factor. There's an inversion in tilt. So we have an anterior tilt, which actually still contribute to the unstable pattern. This is the monitoring of this kind of patient after 1 month of treatment, and we see that we can regularize and stabilize, the function. This is the last and probably most difficult type of patients to address, where the previous placement are not enough, and actually there's a need of involving the serratus anteriors, but actually as we see on the right-hand video, but actually if we go deep into kinematics, it's really interesting to observe what's happened in the protraction retraction curve, because actually we have a really weird pattern which shows clearly that the serratus anteriors is switching on and off continuously in an unstable way, and actually that there's inability or total inability of the rhomboid mid-trap to contribute to stabilize the scapula, and basically that's why we have this kind of pattern. And once again, confirming also what we found in the previous one, we have a complete inversion of tilt also in this group, and that's why the electrode placement on the lower trap is extremely important to help the patient having a posterior tilt and stabilize the shoulder in elevation. So to close, we have identified 3 different ways of addressing posterior shoulder instability. These different conditions are associated to different kinematic patterns. In our experience, the pattern may be modified along the way, so it is not said that if we start from a specific placement, we can keep this placement all over the treatment. Maybe there's a need to further correct down the road. The typical duration of a treatment is between 6 and 8 weeks, and the subjects usually have a good return to their previous activity. Thank you.
Thank you very much, Matteo.
Yeah, there was one question earlier on. There was a question about, probably for Carlos and Olivier, about the question was about for the bone loss. Obviously, in terms of what's your opinion about the bone graft and about if there's resorption?
Yeah, good question. I think Carlos is not here. So yeah, bone will remodel according to Wolff's law, right? So if you have big bone loss, you need a bigger bone graft, and it will remodel accordingly. If you don't have a lot of bone loss, and I admit that I sometimes do patients, like I said, without a lot of bone loss, but where I think the soft tissue will not be strong enough to hold the shoulder in place, I will use the bone block, but a much smaller size, because I'm mostly relying on the sling effect in those patients. So I'll use a smaller bone block and use smaller screws for that. But there will be bone resorption for sure, in combination with remodeling. For the posterior, I think Charles Getz can answer more, but I think that's a complete different situation. Bone block posteriorly tend to resorb even more.
Yeah, and the other thing also just on that is, as you mentioned, I think the sling effect is very important with the lattice, isn't it? That's part of the critical benefit.
Olivier, if I may ask you, which screws, what size screws do you use for your standard lattice?
Yeah, so my standard, I always use the same ones in men or female. Well, men, I use the cannulated titanium screws, 4.5 millimeter diameter, length 36 millimeters. For female patients, I will use a smaller diameter, 3.75, and length 34 millimeters.
Thank you.
Matteo, if I could just ask one last question. In your studies, when you've looked at the pacemaker, did you do any qualitative analysis on understanding what is it about the pacemaker that helps? In that, is it motivation, is it compliance, or is it the feed-forward stimulation that the patients find most beneficial?
Well, actually, it's a very good question. So I think that I have monitored directly myself over 500 patients in the last couple of years. So, and actually, we have measured all of them before and after. I truly believe that, well, actually, compliance is extremely important. And actually, and compliance can be obtained also because patients see generally speaking, an immediate effect, which actually really motivate them to continue to the treatment. Because actually, the initial impression could be not really good, because actually these are kind of patients that are struggling with this problem since probably a lot. And so, you know, they are really demotivated and really they don't see the light. But actually, when they see in the first week or so that they can get benefit, at that point, they are highly motivated in continuing, and I think that this is extremely important. And also, I can tell that probably the most important, the number one reason for getting result is the fact related to the fact that they have a good understanding of what's going on. So they really can feel muscle that they lost in their mind. And so I think that this is the key, the secret sauce of the success.
Thank you.
Are you happy, Anju, done with the questions? Yeah. Thank you, everyone. Thank you, speakers, moderators. We had a great show. Before we end, we're going to do a presentation. Marie, if you could load this, please. So please join us. Well, the first one is about joining the SECEC, the shoulder and elbow community. It's a great educational program which we have rolled out. There's also a SECEC certification examination. So it's a great opportunity to join SECEC at this point. And also we have our regular webinars. The next one is on radial head fractures on June the 3rd. And we have also added on a quiz, and the prize is a great one. You get a free registration for the Rotterdam Congress. So the next webinar is on 3rd, and everybody's welcome to join us at Rotterdam, and there'll be a great Congress in terms of program, and it'll be well attended by all the shoulder surgeons and the physiotherapists. So looking forward to everyone coming over there for a great Congress. Thank you.